Hi, everybody. Welcome to conference today. Please log on to Poll EV if you can to participate. Today we have another basics conference, and the objectives are a little bit loose right now. We'll formalize them at the end of our talk. And so we're gonna look at some images to identify where a bleed is. We're gonna learn about a headache and then a treatment of said headache. And like I said, we'll talk about these more formally at the end. So let's get started with our primer. And so if you can place an arrow on or near the abnormality on this image, which is of a head CT. Yes, the three people that answered the question got that correct. So great job identifying the subtle abnormality on this non-contrast head CT. So what we're looking at here is this, which is an abnormality in the posterior head of the caudate and acute hemorrhage. And then just so you know, knowing that these are not abnormalities, and in fact, they are choroid plexus calcifications, which are often seen as patients age. And so these are not pathologic, and you may see them in patients often. Making sure that you're able to distinguish between choroid plexus calcification versus intraventricular hemorrhages, which often extend from subarachnoid hemorrhages. So you guys got that correct, which is a small hemorrhage here in the basal ganglia. This person would be expected to likely have motor deficits on the opposite side of the body. So why are we talking about this? More and more data is emerging that suggests that COVID-19 patients have a higher incidence of both ischemic and hemorrhagic strokes. They compared the stroke rate in patients with COVID versus patients with influenza, and a markedly higher number of patients with COVID have ischemic strokes. And so just thinking about what happens to ischemic strokes when people are on high dose VTE prophylaxis or therapeutic VTE prophylaxis, we know that these ischemic strokes can convert into hemorrhagic strokes. Both are equally devastating, but I'm going to show you a couple of images of various hemorrhages. So the one we saw earlier was a more subtle one, but this is a pretty large basal ganglia hemorrhage. So this person would have notable deficits. They may have some midline shift here, but it isn't very dramatic yet. Another version that we see are subarachnoid hemorrhage. These you really have to scan for at various levels, but usually present in the subarachnoid space. And like I said, these can extend into the ventricles. And so making sure you're looking at the ventricles for any extension. And then just to round this lecture out, these hemorrhages are not related to COVID and more related to trauma, but just remembering that an epidural hemorrhage has this bean-like appearance, and the dura is containing the hemorrhage here, and then a subdural hemorrhage has this concave shape, usually extends really in the entire hemisphere, and more related to older patients being older in age, and usually occurs a little bit later after the insult, but just recognizing these hemorrhages when you see them on CT scans. So bottom line here really is that you should be advocating for lightening sedation in COVID patients so that you can do an excellent neurologic exam, which you should be doing every day. And then any focal deficits that you may note require a head CT. We had a patient here in the VA ICU that had an aortic valve replacement and was on heparin drip, which was getting turned off and on as he got a trach placement and a PEG placement. Ultimately, we lightened his sedation, found that he was not moving his left upper extremity, and on CT scan had a massive right basal ganglion hemorrhage. What we think happened was that in the turning on and off of his heparin drip, he had an ischemic stroke, which then when the heparin drip was turned back on, converted to a hemorrhagic stroke. So these can be pretty devastating. And so making sure that you're doing really good neurologic exams to the best of your abilities in our sedated patients is really important. Okay, let's get into the case. So pretty bare minimum information today. We have a 20-year-old man who's brought to the ED after he was found altered. So just based on that information and specifically focusing on his age, what questions would you like to ask EMS, friends, and family, since he's not really responding? You have a question in the chat. Ahmed asks about drugs. So this patient's family and friends say that he does not do drugs. He's never done drugs. He's healthy, and he doesn't take any substances or medications. What are his initial vital signs? What do you mean by altered? GCS? Yeah, Kara, those are great questions. So I'll give you the vital signs in the exam coming up next, but know that he's febrile. And then what we mean by altered is that he just seems really sleepy. And his friends say that over the last few days, he's just seemed sort of more and more tired. Was complaining of some headaches, and then today when he didn't go to class, they went to check in on him, and he was just very sleepy and was not waking up. Yeah, Ahmed, great questions. Anybody around him with similar symptoms? Not that he knows of. His friends and roommates say that no one has had similar symptoms. Yeah, any recent trauma? Great question. No recent trauma that anybody knows about. Time length of symptoms. This has probably been going on for like 4 or 5 days. Initially, his friends recalled that he went to Walgreens to get some Tylenol because he'd been having a headache. And then they also noticed that he'd missed a couple of classes because he was feeling tired. They're not sure. They just think that they just know about the headache. Kara asked if the patient had any neck pain or stiffness, and that's what the friends don't know. So good. I think you guys did a great job of asking the appropriate questions, especially when we're focusing just on the patient's age and staying really sort of tied to our illness script here of a young man presenting with some altered mental status. Thanks, Anita. I'll answer that vaccine question in a second. And so recalling that most otherwise healthy patients really shouldn't be altered unless they have a true organic pathology or something like drugs or substances or medication overdose happening. And so you guys appropriately asked about those. You asked about trauma, which is a really common cause of morbidity and mortality in younger populations. And then, you know, of course, a lot of you with the information I'm giving are asking questions about meningitis. And Anita asked, did he get all his vaccines? And yes, he has gotten all of his vaccines. Okay, so we'll move on. You guys can keep asking questions in the chat if you have them. But for Kara and everybody else, here's the exam. He appears lethargic, seems to be in pain with both movement and grimacing when you're checking his light reflexes. Heart and lung exams are fine. He's able to follow simple commands. You have to prompt him a couple of times, but you notice that there are no focal deficits in his arms or legs. And he is able to state his name one time for you. His skin exam is normal. Okay. So based on the information you have so far, what is in your differential and what tests do you want to order? Nobody wants any tests? Okay. CBC, BMP, glucose, that's really smart. EKG and a CT head, okay. Kara asks for an LP and blood cultures. Yep, Kara, and why do you want blood cultures in this patient? Yeah, wasn't he septic? Correct, he was septic. So just to go back to the exam here, he's febrile, he's tachycardic, and right now with his exam and his history, we're most concerned about meningitis, which is a source of infection. So that is the definition of sepsis, which is why we need blood cultures. And then I think these other tests are appropriate. We're going to talk a little bit about the CT head and when we would get one. Anita says, with regard to acute encephalopathy, thinking about mist, meningitis is highest on the differential, but also thinking about metabolic abnormalities. Yeah, great. So we're going to get a full metabolic panel here. Excellent. And then for some patients, if you were not sure about the reliability of family or friends or the patient themselves, it wouldn't be unreasonable to do a urine toxicology screen just to rule that out as well, especially given the patient demographics here. Great. So here are his initial labs, a CMP and a CBC. His EKG was normal, which I'm not presenting here. And then because this patient is septic, it would also be appropriate to do a full infectious workup, which would include a urinalysis and a chest x-ray, both of which were normal in this patient and not something we're going to focus on today. So having looked at this, somebody asked about getting a CT head. And Kara also wanted an LP. So both of those are great thoughts. And one question that I always have to ask myself and remind myself of is, when do you need to get a CT scan before doing a lumbar puncture? And so remembering that there are a few subgroups of patients in whom you need to get a CT before you do an LP. And so these include immunocompromised states, patients that have central nervous system problems like lesions with new onset seizures, papilledema, an abnormal level of consciousness, and focal neurological deficits. Essentially, what you're trying to do with the CT scan in this state is not to rule in anything like meningitis or encephalitis, though you can see some leptomeningeal or parenchymal enhancement on CT. What you're really trying to do is rule out another condition for the patient's presentation, like a new mass, ring enhancing lesions, stroke, things like that. So in this patient, because he has an abnormal level of consciousness, a CT scan was obtained, which didn't show much of anything. And then if you are going to be getting a CT scan before an LP, there are a few things that you should not delay. So before the patient goes to the CT scanner, making sure that you're stabilizing the patient if they're septic, as in the case of this patient. He's a little bit tachycardic, his blood pressure is okay. Both are likely a result of his young age and otherwise healthy status. And so his body is compensating. but some other patients may present more sick, and in that case, make sure you're stabilizing them first. Making sure, like Kara said, to get blood cultures as soon as possible. And then once you've obtained blood cultures, to start appropriate treatment before the patient goes to the CT scanner. And we'll talk about what treatment that is in a patient like this. Okay, so here's the LP that Kara wanted. I'll let you guys take a look at that for a second. And just for references, which you may not have, white blood cell count in the CSF should be less than 5. Protein should be around 20 to 40. Glucose should be 2/3 of the serum glucose. So this is low, even though his serum glucose is low as well. And obviously, gram stain culture should be normal in a person. All right, so based on these LP results, what do you think is the diagnosis? Yeah, great. So the answer here is bacterial meningitis, and we will sort of look through how some of these may present. So I often have to refer to this table when I'm concerned that a patient may have meningitis, just to refresh my memory on what their CSF numbers may look like. But in this patient, he has a really high white count. It was a PMN predominance, so neutrophilic predominance, high protein, low glucose, and we're waiting on the gram stain and culture, but really what we're most worried about in him is bacterial meningitis. So this is a little bit of epidemiology, which we do need to know for meningitis is what is the most common bacterial pathogen that causes meningitis in adults in the developed world? I'll wait just a second to see if people have other thoughts. But yes, whoever answered strep pneumonia is correct. Strep pneumo is the most common bacterial pathogen to cause meningitis in all comer adults. All right, so given that and whatever else you may know about meningitis in this patient, how will you empirically treat him? Remember that the gram stain and culture are still pending. Anita says E as well. So this is probably the most important question we're asking today, right? Because our job as residents, especially when we're admitting somebody alone overnight or without our attending in-house, this is the decision that we have to make about what treatment this patient receives. And hopefully the emergency department will have made that decision for you, because early antibiotics and sepsis is one of two things that saves lives. But sometimes we have to make the decision, right? Kara says D. Okay, so a little bit of controversy here between D and E. The correct answer is D, vancomycin, ceftriaxone, and dexamethasone. And we'll talk a little bit about why that is the correct answer and why acyclovir is not needed in this patient. Okay, so the conclusion for this case, before we look into a couple other things regarding meningitis, is that this patient had acute encephalopathy, was found to have acute bacterial meningitis. based on our LP results. His gram stain grows out GPCs and chains. That should narrow your bug a little bit in your minds. The culture grew strep pneumonia, which is the most common bug for adults. And I think a lot of you sort of asked, or Ahmed asked earlier about whether the patient had close contacts that had similar symptoms. And I think what he was getting at there was Neisseria meningitis, which occurs as outbreaks in close-knit communities, most often high schools or colleges. You were able to narrow the therapy based on the MIC, just to ceftriaxone. And the duration of therapy for pneumococcal meningitis, while robust data does not exist about this, is typically 10 to 14 days. For Neisseria meningitis, it's a little bit shorter, about 7 days. Okay, so identifying a little bit of nomenclature. So meningitis is really sort of differentiated into two big buckets. You have bacterial meningitis, which I'm calling quote unquote septic, but nobody says that, so don't say that, just say bacterial meningitis. And then you'll also hear this term aseptic meningitis. And aseptic meningitis encompasses a lot of different organisms and types of meningitis. So bacterial really has the most common bug, which is strep pneumo. Most college-age people, you also have to consider Neisseria meningitis. Remember that the quad vaccine for meningitis does not cover serogroup B, which causes about 40% of this type of meningitis. And then if the patient is more than 50, pregnant or immunocompromised, you also have to think about Listeria monocytogenes. And then in the immunocompromised population, you also have to think about some anaerobes and gram-negative organisms like Pseudomonas. And then when we say aseptic meningitis, the definition of aseptic meningitis is evidence of meningeal inflammation without positive bacterial cultures or evidence of bacterial meningitis. And so that includes a lot of other organisms that you have to think about. Most commonly, aseptic meningitis is caused by viruses, and even more commonly, enteroviruses, so Coxsackie, echovirus, and then non-polio enteroviruses. Also, virus includes HIV, HSV, West Nile virus, and extraparotid manifestation of mumps, which is meningitis. You also have to think about spirochetes when you think about aseptic meningitis. So both syphilis and Lyme can cause meningitis. And then lastly, you have to think about fungal infections. So Cryptococcus and Coccidioides both can cause meningitis as well. And then TB sort of somewhere in there. Technically it's a bacteria, but it's not as common to see TB meningitis. It has a more, it has a longer course and is usually more slower in onset. And so a word about therapy for bacterial meningitis. So Anita and other folks that answered vanc, ceftriaxone, acyclovir were correct if the patient was completely undifferentiated, the CSF wasn't very helpful or had mixed characteristics, or the patient is in the ICU and so sick that you would be remiss not to cover specifically HSV as the organism. You can add acyclovir, but if you're confident that this is bacterial meningitis, as we were based on the LP, you do not have to add acyclovir. If you've added it, you can take that back. Dr. Albert says that TB meningitis is often accompanied by defects in cranial nerves 3, 4, and 6. Okay, so our ocular nerves. Thanks, Dr. Albert. So as far as treatment goes for bacterial meningitis, the narrowest coverage that you need to give all patients is vancomycin, ceftriaxone, and dexamethasone. And the reason you need to add dexamethasone is because there are a few trials which suggest that dexamethasone in all bacterial meningitis reduces neurologic complications. So this includes focal deficits and hearing loss, and specifically in infections with strep pneumonia, dexamethasone actually improves mortality. So in this patient, it would be really important to use dexamethasone, but really in all comers with bacterial meningitis, you can certainly add dexamethasone up front and then stop that if they have listeria or non-strep bugs and they have a contraindication to steroids. Then to go a little bit more broad, remembering that the next step up is adding the ampicillin in patients that are greater than 50 years old, that are immunocompromised, or that are pregnant. And then a further step up is in immunocompromised patients in whom instead of doing ceftriaxone, you're going to do cefepime because you're going to broaden your coverage to include pseudomonal coverage as well. And so the broadest coverage you can do for bacterial meningitis is this last category here. But remembering that when you have bacterial meningitis, to do dexamethasone early on, especially in strep pneumo, can save lives. Okay, so one last thing here, which is why we are using vancomycin in addition to a cephalosporin. And this is just to remind you guys that while we most commonly use vancomycin for MRSA coverage, and yes, you get the benefit of MRSA coverage in meningitis if the person has MRSA meningitis, which is not very common, we're actually using it for cephalosporin resistant streptococcus. And so strep pneumonia in patients that have had recent antibiotics or just in the community can be resistant to ceftriaxone. And so you need to add the vancomycin to double cover the strep, which is the reason we use vancomycin in all patients with bacterial meningitis, to double cover the strep. Okay, so today we talked about the association between COVID and strokes and looked at a few different types of hemorrhages. We remembered that some patients need a CT before an LP and thought about how to diagnose meningitis, and then talked just now about treatment and who needs broader pharmacological coverage. Acyclovir is really reserved for patients that are really extremely sick, or when you very strongly suspect HSV. Remember that HSV meningitis usually comes as a combo of HSV meningoencephalitis. HSV encephalitis is often located and will enhance the temporal lobe and is highly associated with new onset seizures. And so in a patient like that, a patient that had never had a history of seizures and now presenting with meningitis and new onset seizures, you'd be really suspecting HSV. And that's the person in whom I would add acyclovir, regardless of what their CSF showed, right? Or if the patient is really sick. But if the patient has bacterial meningitis and all the evidence of it, you do not need to add acyclovir. And then for our self-directed learning today, I'm going to give you guys 2 LPs and just to think about what the diagnosis is for each LP. And so you can either take a picture of this or go back and watch the video on YouTube because I'm recording it and answer this question for yourself. But I'll just leave it up here for a second so you have a chance to look at it. And this is really all for the lecture today. So what questions do you all have?
Can you hear me?
Yes.
Is my microphone? Okay, awesome. Thanks. One question, I think you said if, like empirically, if you don't have an LP yet, or it's kind of equivocal, you throw on Dex, even if you don't know if they're bacterial or not, and then you pull it off if they're not. Is that right? Or do you wait to start the Dex until you know for sure it's bacterial?
Yeah, so the guidelines, if you are gonna be, like getting a CT, so the guidelines are that you should try and get the LP as early as possible and await the results before ordering your therapy. But say the LP is going to be delayed for whatever reason, and you can't get in within hours, or this person's going to be going to a CT scanner, which certainly means that the LP is going to be delayed. If you're really empirically going to treat them, I would start with the vanc, ceftriaxone, dexamethasone, and then plus minus acyclovir in that case, depending on how highly you suspect HSV. And then downgrade therapy after the gram stain results. So I would add the dex early on, because remember that one dose of steroids really is not very harmful, and it's these prolonged courses of steroids which then cause all the extra complications. So you can always start it early and then take it back if it turns out that the patient has viral meningitis. But that's a great question. What else? Feel free to send me an email or a text with the results of these LPs once you think about it. All right, sweet. Well, that's all I have for you guys today. Thank you for staying and watching.